me to open it.
Can you hear me?
Yes.
Yeah.
All right, let me see if I can share now. It still says, so you know what, can you share? It still says host disabled participant sharing.
Because you're not the host right now, I am. So I
Oh,
have
you
to-
are?
Yeah, because I had to restart the meeting.
Okay.
So, but I'm admitting everyone right now that is logging back in.
If you want to just make Maarika the host, she has my presentation and we'll just use the same computer. So there's no confusion, and thank everyone for their, I mean, we're navigating things we've never navigated before.
Zoom happens.
Zoom
happens.
happens.
That's a great meme.
I'm back. Good morning.
Good morning.
Okay, I have 24 people on right now. So I think everyone has rejoined. Thank you again for your patience. Maarika, I'm going to make you the host. And then you should be able to share your screen. So on my end, it says that you are now the host. And I show Maarika that your microphone is muted.
Okay, sorry. We were trying to, I'm trying to let people in at the same time too, so.
Yeah, I'm sorry.
No, it's totally okay. All right, okay, so I'm gonna do share screen and share presentation. And,
Okay, it says you have started screen sharing.
all right, can everybody see that?
I can see you, I can't see your screen. A note did pop up that you had started screen sharing, but now I see you and Melinda again.
Do I do screen or not? I don't know. Look on me. Oh, it's coming.
There, oh, I just saw it.
All right.
I can see your presentation, Melinda.
Excellent. Okay. Thank you so much. Finally, thank everyone for their patience. We appreciate you all and navigating this interesting world that we are now managing through in the virtual world with presentations. So thanks so much. All right, everyone, good morning. Thank you. I know it's post-Sunday Halloween. Any of you who have any little children or grandchildren, it was definitely a lot to get up on a Sunday and to be ready to listen and learn about the two topics you're going to hear about today. So as Jean introduced, my name is Melinda. I'm a director of operations for Fresenius. I oversee currently 9 dialysis centers, and I've been a dialysis nurse for a really long time. Some of you I know through our shared work, and for those of you who don't know me, my work here with the ANA is extremely important to me, and giving back to the nephrology community is something that's near and dear to my heart because I care so deeply about the staff. And my philosophy has always been that if we care about our staff and we empower them, engage them, and take care of them, they will provide the most exceptional care to our patients. So what I'm going to be chatting with everyone about today is, I'm just moving over this block because it's right my way. Is about coronavirus. And so I'm betting my life on the fact that each and every one of you have either heard of coronavirus or you've been touched by it in some way in your work or in your personal life. And so with that being said, with the education committee, when we were working on our presentations and getting ready to serve what we were going to serve for all of you today, we discussed that coronavirus would be an important topic. And so the goal of today, I'll get into the objectives in just a moment, but the goal of today really is to give you a basic overview of some of the experience that we've seen in certain pockets of the local area. And what I mean by that is New York State, tri-state area in regards to coronavirus, specifically to the ESRD community and also to the community at large, because we saw, we'll discuss in just a little bit, an uptick in AKI or acute kidney injury related to coronavirus. Okay, so let's get started. So I thought this, again, I apologize. I'm trying to maneuver this box of, maybe I can just make it low. Perfect. Oh, there we go. Great. Okay, so this quote really stuck out to me when I was doing my research and going through the literature about COVID. And it says, "We cannot say this loudly enough or clearly enough or often enough. All countries can still change the course of this pandemic." And even though currently in the United States, we're about 7 to 8 months in to our true coronavirus pandemic, we still have the ability as first line and healthcare providers to help change the course of this pandemic. And I think through our discussion today, we'll start to gain little nuggets of information and ideas on how we have, each and every one of us has a role in managing through how the spread of this pandemic can be altered. And in addition, our role in caring for those who do obtain the COVID virus within our ESRD community. So the objectives for our presentation today are to discuss what is COVID-19. It's generally speaking, we know it's a coronavirus, but I think it's important to just take a little bit deeper dive into what that really means. Discuss how COVID-19 affected the nephrology community. So for some of us, and upstate New York, a little bit less than downstate New York, some clinics had, outpatient clinics got hit really hard by their staffing being affected by COVID-19 and actually staff becoming ill and then not being able to care for our patients in outpatient as well as inpatient setting. So COVID-19 definitely had an effect on not only our patients, but our staff, and where you are geographically, that may have touched you differently. So we'll chat a little bit about that, and then examine the next steps for pandemic preparedness in the ESRD community. Because I know from my own personal experience that we were not prepared for how quickly and intensely this pandemic hit us and the effect that it had on our population. Okay, so first off, what is COVID-19? COVID-19 is a coronavirus, and coronaviruses are important human and animal pathogens. In fact, there are thousands of coronaviruses, and typically they are circulated amongst animals. Pigs, camels, bats, and cats are the most often affected by coronavirus. However, coronaviruses do have the ability to cross from animal to humans in certain circumstances. And so in approximately November of 2019, coronavirus made a transition. Some folks believe it may have been at a wet market. There is an actual literature that states the true epicenter of where the virus actually manifested from, but the belief is that it came from a wet market in the Hubei province of China in the city of Wuhan. And so somewhere along that time frame, there was a transition from an animal to a human of this specific coronavirus. It was officially named Severe Acute Respiratory Syndrome, or SARS, which we have heard about in the past. I'll talk about that in a minute. Coronavirus 2 by the International Committee on Taxonomy of Viruses. And then in the February 2020 timeframe, the World Health Organization designated the disease as COVID-19, and that stands for Coronavirus Disease 2019. So I think the real important takeaway here is that coronavirus is not new. This specific strain of coronavirus, and we'll chat a little bit about that, is new. However, coronaviruses have been in our environment, and they have been most predominantly seen in the animal population. So it's important to take a global look when we're talking about coronavirus or any infectious disease process for that matter at what is an epidemic, an endemic, and a pandemic, because depending upon how the population you serve or the area geographically in which you live is affected by a specific infectious agent, you might not recognize where your specific geography stands in that. So according to the CDC, an endemic refers to the constant presence or unusual prevalence of a disease or infectious agent in a population within a geographic area. So according to the literature, sometime around November, December of 2019 in Wuhan, physicians were identifying that there was this extreme pneumonia or respiratory illness that was starting to be identified in clusters. And so it was at that moment that they started to recognize there was an endemic that was going on in that particular area. And as these clusters started to develop and spread, it was recognized that they were moving into more of an epidemic, because the increase in this specific virus response that disease response that they were seeing was spiking very high and very quickly. And then quite quickly, over a period of just a couple months, this virus that again was later identified as COVID-19 started to be seen in different areas of the world. And in the United States, we started to see that rapid spreading starting in the Washington State area and the California area in just about February, March of 2020. And so a pandemic, which is where we are right now, actually refers to an epidemic that has spread over several countries or continents, and it usually affects a large number of people. And with it rapidly spreading, that is where we started to hear the new termination, not new termination, it's been around for a while, but the terminology of social distancing, which started to come in. I know I remember hearing about it, starting to see it on the news about this new pandemic that was starting to be identified and how we were going to stop the spread. So we'll talk a little bit about that in just a minute. Okay, so how is COVID-19 different from other viruses? What's important to identify is that COVID-19 actually has a couple different strains. There's not just one specific strain of this virus. And depending upon the strain, the mutation that stabilizes the virus itself is changing and can be different. So according to research from the Scripps Research Department of Immunology and Microbiology, this specific strain of COVID-19 that was found in Europe and the United States has a genetic mutation that increases its viral ability. So there is a mutation called D614G that is on the specific viral pieces of COVID-19 that were found predominantly here in the United States that increases the stability of the virus itself. So it contains a tripod spike, which if you take a look at the little, visual here on the side, you can see it has 3 points. So this tripod spike is really unique to this specific virus. And because of the way the spike is built, it actually has 2 different segments, an S1 and an S2, and it's extremely strong. So in actual travel within the body systemically or moving from host to host, depending upon if it's droplet or aerosol, it's strong, so it doesn't break away. So it has more of a chance of being able to get to its host and infecting healthy cells. So with that, this specific mutation is what has propelled its virulency within the populations, why it's spreading so quickly, why even if there have been other coronaviruses that folks have been exposed to, say, through some type of cold process that was as virulent as it was, because it was new and it had this specific mutation on it that made it very strong. With that being said, there is a new mutation that's been identified. It's actually not that new. It was identified just a couple months ago, but we're starting to see that it's rising now that we're entering the fall and winter months. And that's the G614 mutation. Now, what's being identified in the literature is that this specific mutation, it is less virulent, which means the disease process that we're seeing doesn't get quite as severe. However, this specific gene mutation does again allow itself for building strength of that actual infectious particle, and therefore it is spreading very quickly because the virus itself is strong and it doesn't break down in transit, and the body has a hard time fighting it initially. So what we've seen is typically that when the individual is exposed to the virus, it is about a 2 to 14 day incubation period. Okay, so now that we have a basic understanding of what COVID-19 is, and again, there's still more to come. We're just at the tip of the iceberg with this virus, and how it will mutate and what it may look like for us in months or years is significantly different than what we see now. But with that foundation being laid, now let's take a look at how has COVID-19 affected the nephrology patient community. So let's get started. So what you see before you is a visualization of how of two different ways that our patient populations have been affected by COVID-19. So there's the second degree infection process. So if someone has been infected with COVID-19, they can have multiple different types of manifestations of the infection. So some folks may, depending upon the severity of the disease, have an immediate systemic inflammatory process. And it's been identified that the disease is a disease of inflammation. So whether that's what we're seeing majority of is that inflammation of the respiratory system. What we are seeing is that it is systemically inflammatory. And so with that, human beings are being affected by it differently. So there are some folks who will get a rhabdomyolysis or a breakdown of their muscles due to the infection and how the process is working in their body. Or they'll become septic and then they have that endotoxin shed. And so all of those different pieces play into congesting and affecting the kidney in a way that prevents it from filtering as it should. And as that happens, because it starts from an initial process, it becomes a secondary infection, a secondary response in the kidney, we see that the kidneys start to go into either acute kidney injury, or if a patient has an underlying CKD diagnosis, say they're in stage 1, 2, 3, or even 4, we see a propelling of the kidney disease because there's this damage that's being inflicted on the kidney from this secondary response to the infection. In addition to that, there's a primary response where just the result of the inflammatory response of the kidney, the epithelial and endothelial cells within the kidney itself to the infection, there's a primary damage that's happening to the kidney. And so we see that with the collapsing of the, I tried to remember this word, everyone, glomerulopathic. So the actual collapsing of the ability of the kidney to filter toxins, to filter waste. And so with that, in addition, they develop the kidneys, that microtubulars inside, we see that the endothelial damage with the thrombotic microangiopathy. And so that's the primary infectious rate, primary damage that happens to the kidney specific from the inflammatory response. So the kidneys really are taking a significant brunt with this infection. And I think what we've all been conditioned to by, say, the media or just word of mouth is that it's primarily an infection of the respiratory system. However, I'll show you some statistics in just a little bit that shows that the kidneys are significantly affected by the virus as well. So just a snapshot of one healthcare system for acute kidney injury. The Mount Sinai Health System, they researchers from this specific program did a retrospective chart review, and they identified that between February 27th and May 30th of 2020, of the 3,993 patients that they had hospitalized with COVID-19, acute kidney injury occurred in 1,835 patients, or 46% of patients. So of all folks who were diagnosed with COVID-19 and in this specific hospital system, regardless of whether or not there was any type of diagnosis of ESRD, there was no diagnosis of ESRD, AKI occurred in 46% of those patients. And then among those patients with acute kidney injury, 349 or 19% of them went into the need for dialysis intervention, and half of those folks did die in the hospital. So as you can see, this virus, regardless of whether or not it is identified as a respiratory specific virus, that the kidneys in almost 50% of all of our patients that were admitted into this one system had some form of kidney damage related to being infected by COVID-19. So I think for us as a community, a takeaway that we want to make sure that we keep in the back of our minds is the fact that even in just this one system, 35% of those folks who had AKI while in the hospital, once they were discharged, they had not returned back to their basic kidney level. So whatever it was previously. And so we have to start thinking long-term about what does this look like for all of us in the future. And I think we'll see a lot of studies. Again, we're still so new to where we are with COVID-19. However, I don't think the long-term lasting effects of what our patients with COVID-19 have gone through will not touch us. It will continue to touch us for many years to come. Another population within our ESRD community that was affected significantly by COVID-19 were kidney transplant patients. So those folks, because of the immunosuppressive drug therapies that they're on, were at a higher risk of being infected with COVID-19, and in addition, having severe disease. So in one small study of 36 adult kidney transplant recipients who tested positive for COVID-19, 78% had to be admitted to the hospital. 10 of those 36 kidney transplants, and then 7 of 11 that needed to be intubated, they passed away. And so this particular population, kidney transplant recipients, they had a higher death rate because of, or the belief is because of their immunosuppressive related to their immunosuppressive drugs. And so this particular population of patients is extremely vulnerable to COVID-19 and to the long-term effects, again, of either the transplant itself or the allograft being affected and being damaged, or they themselves, because of the immunosuppression, succumbing to death because of this disease. So the current reality too, for many folks waiting for kidney transplant, is that kidney transplants are actually have decreased significantly since COVID-19 has come to fruition here in the United States. Many programs shut down completely for some time, and then there are multiple programs across the country who are taking a very stringent approach to who is getting transplanted. So certain folks who are on erythromyoglobulin and a lemtizumab, in order to be able to get them prepared for kidney transplant, are currently, most programs are not allowing those folks who would need that type of therapy to be, they're on hold right now for transplant. And in fact, I just met with a patient this past week who, I have to be honest with you, I didn't know this was even possible, was advised within his own state that his kidney transplant would not be able, he would be put on hold and was not able at this time to be consistent on the list. Will be going to a state out significantly farther away to try to get on a list so that he can move forward with getting his transplant. So this specific disease has had a significant impact on those folks who are waiting for transplant. Okay, sorry, the block's in my way. So an increase in acute kidney injury. So this is specific to patients with no previously reported kidney disease. So research or the literature has shown that 33.9% of all patients with COVID-19 and 78% of patients in intensive care develop acute kidney injury. Now, that doesn't necessarily mean that they need to have dialysis. It just means that their kidneys have been injured in such a way that they are not functioning at the level that they should be. So for 13.8% of all patients and 35.2% of all patients in ICU required inpatient dialysis services. And so we're going to hear a little bit in just a little bit about what that was like for just one program when there was such an increase, an influx of folks who needed to have dialysis services. And this was a challenge because, quite frankly, we weren't prepared. The community as a large was not prepared for the level of acute kidney injury that was going to happen to folks who were infected with COVID-19. And we were not prepared with the supplies, machines, and personnel that we needed to be able to care for the influx of folks we were going to have. So a result of a large scale study of nearly 4,000 patients at the Icahn School of Medicine at Mount Sinai suggests that nephrologists will need to prepare for a significant uptick in patients with chronic kidney disease and a result or exposure to COVID-19. And that kind of ties back to what I was talking to you about before. We're just in the beginning stages of how this is going to affect our community and our work as nephrology nurses and technicians in the long run. So it's also important for us to take a look at how COVID-19 has affected different racial and ethnic groups, because it's not consistent across the board. So what we have seen thus far, and this slide was taken directly from the Centers for the CDC, is that those folks who are non-Hispanic, white, American Indians, they see a 2.8% increase in cases. We're seeing in Asians and non-Hispanic a 1.1 time higher infection rate. And then in Blacks and African Americans, a 2.6% higher infection or number of cases. And then with Hispanics, that's 2.8%. So I think what's important to take a look at is our death rate. So for Indian and American or Alaska Native, that's 1.4% higher. Their death rate, the amount of folks that die within this population, is 1.5% greater than white non-Hispanics. We see a 1.1% in Hispanics or Latino persons, but I think it's important to notice that there's almost a twofold increase in Black or African American folks in their death rate when it comes to the infection of COVID-19. And in the next presentation, this will be touched upon a little bit more, but I think it's really important for us globally to take a look at how this is affecting, how this virus is affecting our population that we serve. So acute programs generally speaking in the metropolitan New York area, at the peak of the pandemic within that March and April timeframe, they saw a 3 to 4-fold increase in treating acute patients. For example, Montefiore Medical Center in the Bronx, they opened 6 days a week, dropping treatments for patients to 2 days a week. They had to change treatments from 3 hours to 2.5 hours. And then a lot of the work that they did was medically managing the patients the best they could with drug therapies. And so there was a point in which in this particular hospital system where they had exhausted their ability to treat patients with conventional dialysis machines. And so they actually used emergency immediate start acute peritoneal dialysis to bridge the gap to serve some of these patients. And so there's some stories to be learned from this because I actually work with one of the physicians that was part of this and utilized the emergent start peritoneal dialysis to serve some of her patient population. And if any positive came out of this particular time was that a physician who was skeptical and pushed back about PD saw how emergent start peritoneal dialysis saved lives of her patients. And now that we're a little bit out of that crutch, she is now directly admitting her patients to PD. So I think we are going to see a lot of that kind of physician change and forward-thinking mindset because of some of the negatives that happen. Some positives are coming. One of the other effects that our community saw, not only in acute programs, but also in the outpatient facilities, was supply shortages. So generally speaking, I can tell you that we were not prepared for a pandemic. I worked in the education department of my specific organization for many years. We did not train or have a training program that talked about pandemic or pandemic preparedness. And so I think what we've all learned from this is that we as a healthcare system, not just specific to dialysis and dialysis services, have to take a broader look at what it means to have the threat of a pandemic be real to us at all times. And so even though many will say we haven't seen a pandemic of this proportion since the 1918 flu, who are we to say that it's going to be another 100 years before we see a pandemic like this? So we identified the community and the literature that we had machine crises. We had, I know in one of the acute programs that we work with in New York City, we flew machines from California to New York. Fluids, unable to have the fluids we need, dialyzers, we didn't have enough beds, and staffing. So these are all things that we need to look forward to plan ahead for the future. In chronic outpatient hemodialysis, we saw a big change in the way we had to take care of our patients and how we prepared our staff. So we identified that the CDC identified, and each organization took extra steps as well in screening measures, masking, PPE, the amount of PPE we needed, how much PPE we were able to use, taking, for granted the fact that we could change our gowns all the time, or that masks were readily available to us. And in some organizations, all of a sudden we were being tasked with having to only utilize X amount of masks or X amount of gowns over a period of time. We had to develop the ability to cohort patients, because we had to develop a person under investigation, as well as COVID positive shifts, as we started to take care of these folks in the community. And then one of our biggest challenges was staffing, as not only were initially in this pandemic were our staff fearful, and they're still fearful, but also they were getting sick as well. And so who was there to take the place of those who were getting sick in the community and unable to help care for our patients? So this virus has had such a profound effect on our community, not only for the patients, but for us as well. Many of you who worked in clinics or who work in clinics, I currently have some clinics who have patients who have been tested and are positive for COVID-19, or coming out of the hospital and they are still positive. We have had to develop isolation shifts to cohort them away from patients who are not infected with the disease. And then in addition, those folks who may be screened, we've had to come up with PUI shifts. Again, extending our days, put taxing to our staff, pushing folks beyond limits that we've ever had to push them to, and affecting a lot of us mentally. Also, for those, another big opportunity has been for those with families, and as finding caregivers for our children. So having these extra shifts has put a hardship on our staff. So for PPE, many of us know that the N95, if you are working with patients who are positive or patients under investigation, is the mask of choice. It is preferred because it is specifically fit tested or seal tested to the staff member to ensure that it is provides a seal to allow to not allow droplets or aerosols to enter or exit from the mask itself. Eye protection, specifically goggles, not just glasses, but goggles that actually cover the eyes and the sides, again, due to droplet or exposure from coughing, and gloves and isolation gowns. So these are the basic needs that we had, and in some instances and in some organizations, depending upon if you were acute, not acute, and where you worked, you might not have had access to all of what you needed. So with that being said, we have two guest speakers here today to talk a little bit about their experience with COVID-19, and to give all of you an insight into their lived experience. And for many of us in more of the upstate part of New York, we weren't hit as dramatically with COVID-19 as we saw in the metropolitan New York area. So with that being said, I'd like to introduce to all of you Fabella Angood. Fabella is the administrative charge nurse for inpatient services in Long Island. And Fabella has graciously agreed to speak to all of you about her experience with COVID-19. Fabella, are you there?
Hi, good morning.
Hi.
Hi, my name is Fabella Angood from Fresenius Acute Inpatient Dialysis. I would prefer not to relive whatever I experienced during those times, but I would love to share my story. We started having COVID patients like month of February. Month of February is not so bad that I was able to assign like one nurse to do each COVID patient. Like at the beginning, we were able to do bedside dialysis because it was not that bad. But then when the month of March, April started, then it got like out of control. Usually our census for acute, because me and my staff, we cover like 3 hospitals in Long Island. We have like Good Samaritan Hospital, St. Joseph Hospital, and St. Charles Hospital. So on that 3 hospital, I cover the staffing. So for the month, when the month of March started to come, and our census from 21 went up to like 40s, 50s, and 67. I only have like 14 nurses to split on the 3 hospital. I think that was the time that we all realized how much dedication we have on this profession. We were working 14, 16 hours every day. We open Monday to Saturday, and then we have on calls from 7 p.m. to 7 a.m. because the acute clinic opens at 7 in the morning, which is the regular hours. And on Sunday, we do have like 24 hours on call. From 14 nurses, I lost like 3 nurses. Like 2 nurses resigned because they can't handle the stress and the fear and the panic. And I have 1 nurse who applied for medical leave, and the leave stated that she's diabetic, and she's like at a high risk of contacting the disease. I am diabetic myself. I have hypertension also, but I can't see myself like walking away. And I appreciate all the dedication of all the staff. It was like crazy. Everyone was like working 14, 16 hours. And every day I was arguing with all the doctors. There are some doctors that's like really good. They agree, because sometimes like every morning I'll come. I will set like plan for the day. I will have list of patients. I will have the numbers of every patient, their potassium. And some doctors, they will agree to sit down with me because we have to prioritize who needs the dialysis first. And it's going to be based on their age, based on how sick they are, based on how high their numbers are. And it's so sad that sometimes you have to push away some other patients because you're not sick enough. You're not unstable enough. Like, you're going to live for 24 hours without getting dialysis today, so we're going to push you back for tomorrow. Like, it's so bad. And some doctors, like, I know that they're the one doing the orders, and I have like a couple of arguments with some of the doctors because they will tell me like, they're the doctors, they're the one doing the orders, they're the one writing the orders, not me. But like, one of the doctors also threatened me that I'm going to call Department of Health because you're refusing to send me dialysis nurse. And it happened in one of the in one of the hospital. And I even said to the doctor, like, oh my God, can you please call whoever you want to call and complain, because maybe they're hiding dialysis machines somewhere, or maybe they're hiding dialysis nurse somewhere in their building that they can send us help. And also they tried to suggest to open like 7 days. And I said to the doctor, like, we can do 7 days, but all these nurses are working 5, 6 days already for like 14, 16, 18 hours. I said, like, they all need to at least have a 1 day, a decent day to sleep and recharge for another 6 crazy days of nonstop working. I said, these nurses, they need to sleep because they're human, or else they're going to get sick. And then you're going to end up with 0 nurse one day. I said, you have to take care of these nurses. It's a constant argument every day. And there are days that it's so good that you have a good result, like positive outcome. And there are days that like, oh my God, what's wrong with them? And you know what the sad part is? These doctors, they don't even see the patient. Sometimes they just make a phone call because every patient has their own phone. They have their own phone. They don't go inside the patient's room. They just make a call and say, is everything okay? Okay, this is the plan. Unlike the dialysis nurse, especially the bedside dialysis, where you from setting up the machine to doing the whole treatment from beginning to the end. And then like everything, you have the whole time beginning to the end exposure to that COVID patient. And that's why I said to the doctor, like, you have to put yourself in that situation. I said, you being the doctor is either you're staying outside the patient's room and look at the patients from the window, from the glass window, or you're calling the patient on their phone and you're doing like a phone assessment. I said, these nurses is actually there, like few inches away from the patient, and they're doing the bedside dialysis. And also the other thing is we also have a big dialysis unit in Good Sam. Good Sam is like one of the busiest hospital in Suffolk in Long Island area. So we have so many patients, and we have like a big dialysis unit that has like 8 beds with heart monitor in each bed. So at the beginning, we were able to do non-COVID, and then we all do COVID patients bedside. But then when it got like really crazy and out of control, the hospital said, okay, we have to start doing COVID in the regular unit. At first, I was not agreeing with that. I'm being protective of myself and I'm being protective of my staff. But there's no way that we can do bedside dialysis to every COVID because there's so many of them. So we started bringing patients to the unit, and just to think like the unit is not a negative pressure unit. We have 2 isolation room, but it's just a regular isolation room. So like I always have to communicate with the hospital administrators, because I have to present what we need. I said, okay, we're bringing these COVID patients to the unit. Is there any way that you can provide like some protection for us? They brought us like HEPA filter, which I don't know if it protects us 100%, because I know it's just purifier the air, but it's not like a negative pressure room kind of protection. But that's the only thing they can do because everyone was not prepared for this COVID. And for the nurses, I felt during that time, I'm kind of like a mother, even though some nurses are like 10, 20 years older than me, because I keep on reminding everyone, eat. I keep on reminding everyone, did you take your vitamins? Did you take your zinc? Did you take your, like anything just to protect yourself? And because we kind of like help each other. I think we built so much like strong bond during that time, because we know we don't have anyone except each other. I was constantly in communication, even with Fresenius. Every time the hospital is giving us a hard time, I will call my boss, because technically the hospital should provide everything that we need from PPE. But there's like a shortage with everything, from staffing, from PPE. We have shortage of machine and portable RO that we have to get some machine and RO from Pennsylvania. But and then we ended up having so much machine and so much RO, but then we don't have enough nurses. And I remember also like the community in Long Island, they are so good to the medical people, to the medical personnel, that they were supplying food to the hospital. But then us, the dialysis unit, not being employed by the hospital, those food doesn't reach dialysis. I have to send like a letter to the administrator, because I said like, hey, listen, just to let you know, we're working like 16, 18 hours every day. When we come to work, there's no store open. When we're done, all the stores are closed, and we just have like 4 or 5 hours to sleep to come back again. I said, is it too much to ask? Like when you have donation from the community, like send us some food, because we see some foods being thrown away. And that's the thing, because I think we're kind of like forgotten because we're not part of the hospital. That I have to constantly remind, okay, we're not part of the hospital, but we're providing dialysis to the whole hospital, to all your patients. Like, can you include us, whatever good things you're getting from the community? And like, you need to be able to present the unit and present your people, your staff, or else we're just going to be forgotten. And to think how COVID affects the dialysis patients, like even the doctors, like no one at the beginning, no one has clue like what to do, what kind of approach to do. All they know is most of these COVID patients will become a dialysis patients because the virus is attacking the kidney. But they don't know the right approach. They don't know the right medicine. They don't even know, like they said, okay, some patients have like clotting disorder, but then at the same time, they also have like bleeding ongoing. So they're all confused what to do with patients. Like they are a stable patient and all of a sudden they stop making urine. But it's the crazy months. And I'm really hoping, now, reading the news, they say we're going to have a second wave, but we're all hoping that it's not going to happen again. Like, I know we're going to have some cases, but we're all hoping and praying not as crazy as that, because it was really bad. We were unprepared, but the fact that we survived, it's a good thing. And I said to my nurses, like you guys stayed, so it's a good thing. That means we are very dedicated in doing this job on this kind of profession. And I said to myself, even myself, like I've been working as a nurse for like 19, 20 years. I never felt how much dedication I have on this job, on this profession, until this COVID comes. And it's a crazy experience. But then at the same time, I would say it strengthened everyone, especially I'm speaking for my team. I have a great team.
You certainly do, Fabella. So thank you so much for sharing your story with us. I think for many of us who weren't in the thick of it like that, what you've brought to the forefront for us really hits home. And as nephrology nurses and nephrology technicians and folks who support the nephrology community, we can all get a feeling of what that stress must have been like for you. So thank you so much to you and your team for all of the work that you did to support our patients. And we are so grateful for you.
Thank you.
Thank you. Next, I'd like to introduce James Shembry. James is currently an area team lead in the Long Island area of Metro New York. And James had a similar but different experience in the outpatient world of working with COVID at the height of the pandemic. So James, if you'd like to share some of your experience with us, we'd love to hear it. Thank you.
I show that he's unmuted on our end.
I can't hear you.
James, can you unmute your computer? I'm showing on my end that you are unmuted. Try turning your volume up.
How is that?
Excellent.
Yay.
Hello. Well, hello, everybody. My name is James Shembry. I am really great friends with Melinda Myers. She's kind of my Maarika, my Donnie. And I think that really, I was kind of really thinking about when she asked me how I was going to approach talking about this. And just to, be forewarned, I'm kind of a live wire here. So I'm going to try to keep it a little PG-13 for you guys. But this was by far probably one of the most, like just an amazing experience all around, whether it was bad or good. I remember talking about this with Melinda on phone calls going, are you hearing about this? This is, this is, and we were even kind of saying like, I think I got it. Like, I think I had it. Like, do you think, and this was probably like around in February. And I also have a wife that is a nurse, a critical care nurse in the hospitals, in one of the biggest hospitals on Long Island. And I remember her coming home every day, and she's probably about 7 months pregnant, about February. So she's doing critical care, and she says, this virus is coming, and it's literally just kind of like overloading our hospitals. And there's 9 floors, and there's about 3,000 beds, and just floor by floor, it was just, she said, oh, they turned floor 9 all into this COVID floor, and they turned floor 8. And every day she would come home, and I wasn't seeing it just yet. Like in the outpatient center, it was like, Fabio was saying, we're kind of like this like separate community. So we weren't seeing it, but we were very alarmed because we have such a huge risky patient basis and demographic with their immunosuppression, just the compromise of what ESRD does. So we started really planning on what we're going to do. How are we going to separate patients? How are we going to do dialysis and keep our really immunocompromised people safe? And I think that really it was a total change in operational, what we had to do. I was a quote unquote education manager. So I was really kind of off patient care. I was really managing a team of educators. Immediately, I was thrown back into the front lines. It was like, if you had an RN after your name, you were putting on scrubs and you were doing PPE. And I went from the day job of communicating with all the regional leadership to setting up the first COVID testing sites for Metro New York. And that was something that was remarkable because the company, Fresenius, that I worked for, what they did was they really kind of said, we have no protocol for doing nasal swabbing for this. There's no protocol for this. So we had to make up a policy on the spot. We had to really kind of shoot it through a lot of people. And then predominantly what a procedure was historically done by NPs or our higher licensure nurses was now thrust upon the nurses that were already overtaxed testing patients. So I think that it was just a very trying time for nurses where there was a lot of different information going out. No one really had a clear view on what you're supposed to do. And I think with all the nurses on the phone, that's what we want to know, right? We want to know A, B, C, this is what we do to keep ourselves safe and our patients safe. And I think that was in the beginning, it was so hard to prepare for. And really what I noticed is despite how much we did prepare for it, despite all the testing sites that we got up and running, despite all the kind of like, listen, this is going to really hit us hard. Where I predominantly am is right on the border of Queens, which is known as the world's borough. There is, it's the most diverse place on the entire planet. There's 111 languages spoke and over 2,000 dialects just in that little borough of Queens. And the healthcare is a vast spectrum of who understands infection control and who doesn't. And I think that really when it hit Queens, as much preparation as we had, as much preparation as the New York metropolitan area had, it was like a tsunami. There was not enough preparation that we could have done. It was unlike anything we ever saw. We had nurses going out, we had patients going out, we had this plan of opening up these brand new clinics that we're going to open in a year from now. We open them up now to kind of overfill from the COVID people. And there were supposed to be 1 or 2 shifts. They were immediately filled in 2-3 weeks to the roof. We were having hospitals ask us, can you guys take 400 patients? Can you guys take, and as we're doing this, we're trying to set up, trying to keep our own patients really kind of healthy, and we were doing good. And then really what happened was, this was about the time when I was opening up clinics in the Bronx and then driving in the morning and going to close clinics in Brooklyn, probably for about 6 days straight. We started noticing this real high increase of staff getting sick. And that's what really scared everybody, I think. I think that everybody in the dialysis community is almost like infection control experts when it comes to everything else, because we have this really high acuity for infection and how we appropriately wear PPE. But I think that once it started breaking down those barriers and I was working in so many different communities at the time, just doing and mitigating it, that's what really the fear started setting in. That's when they were that's when the shortage started happening. That's when you were having PCTs doing like 1-7, 1-8 ratios, nurses working on like 16 hours, and they're going in for another one, maybe getting a couple, so maybe an hour or two sleep in the back while, the machines reset, and then they would kind of go back at it again. It was just trying to stay afloat for a good, I think that's what the hard part was too, was for so long. It wasn't, I think that when we were having these big leadership calls, the best thing I heard was, even when you have a hurricane, the hurricane comes and goes, and then you suffer, of course you suffer for 3 days, and then everything gets rebuilt after that in weeks, and it takes preparation. The hard part about the coronavirus in the metropolitan is that hurricane lasted for 4 straight months. So no one ever got to catch their breath. Like I said, me and my wife were having a baby right in the middle of it. So our baby was born April 19th. She was actually taken off the floor because her 3,000 bed unit had 0 beds that were not COVID positive. Every single bed was taken. My wife actually delivered in an ambulatory surgery center, and then her maternity ward was the lobby of that ambulatory surgery center for 12 hours, and then she was discharged home after a birth. There was nowhere to keep her. And while I'm doing this, I'm going back and forth setting up clinics. And so we actually suffered personal loss as well. We had on the Long Island and Queens area, we had a remarkable number of staff actually get severely infected and sick. And we actually had quite a number of staff actually pass away from the coronavirus. And really, just as a nurse, it was really a changing point in everything. You couldn't, for me personally as a nurse, I couldn't be in a position where I wasn't actively helping people get better in the worst, triage moment in history for nursing that I've been around. So I think that we had a clinic manager that passed away from this, in towards the south end of Long Island, and his staff and the clinic there was deeply affected. I mean, the entire staff got sick. They lost 40% of their client basis due to COVID. That's where it just was like a wildfire in that clinic. And really everything changed after that. A lot of people just took to arms, and really it just got so, no matter how much you worked, it was like this adrenaline shot. It was like we weren't going to give up. No matter how much they hit us. And then we just started turning a corner. But it was the hardest part of my entire life ever. And I really do think that when we do talk about a second phase or a second anything, I think probably anybody been a part of it, whether about how small or how big you were involved in it, you're going to have some sort of PTSD from it. I think that now even there's so many nurses from this pandemic, but it was one of the most proudest moments and one of the most craziest moments of my entire life.
Thank you, James. And the only piece I can add to that before we finish out the presentation is that I had the privilege of supporting the metropolitan area. Again, this is through Fresenius, but we had a volunteer system set up. And between March and May of 2020, we had over 370 volunteer nurses and patient care technicians come from all over the country to help support us with caring for the number of patients that we had, the PUI and COVID positive shifts, in addition to taking positions where staff were out sick. So it was a true, community effort. How we were able to survive as a nephrology community, what the tax that this disease had put on the metropolitan New York area. So thank you again, James, and thank you, Fabella, for your story. I thought it was really important for all of us to be able to hear their stories. Okay. So to try to get things wrapped up because we have, we have a phenomenal next presentation. What next? So you heard some of the live experience. You have a basic foundation of what the coronavirus is and what it means to be in a pandemic. So some of the takeaways that we're gaining as a community is first and foremost preparation, ensuring that we have enough PPE available for all of our staff to be able to care for our patients. Don't forget to mute your phones, folks. Mute your screens, mute everything, so that we are prepared should we have a second wave of corona. But not only that, for the future, we have to prepare. Education, as I told you previously, I was the education manager for the entire region for many years, and pandemic education was not part of the work that we did with our staff or our patients to prepare them for what it could look like should something like this happen. So I know already that we as an organization are working on developing those plans and that strategy. We've come up with some very on the fly education and preparation, but we're looking to put a long-term strategy in place. Surveillance and testing, because we know that testing is the key to helping us keep folks separated and socially distant as well as isolated so we don't continue the spread. And then again, supply chain management, swift allocation, and no bottlenecking of supplies so that our staff have what they need to take care of our patients. The future planning, again, we've already touched on these pieces, but another important piece as well is getting back into nursing school, going all the way back to medical school, and ensuring that all of frontline workers in healthcare have an understanding of what it means to care for patients and care for yourself in a pandemic. So what can you do right now? Well, we can all say we know what to do, but maybe we don't. Make sure you're washing your hands. Social distancing, as I said before, I've always thought of myself as being pretty well read and having a good understanding. Social distancing was a term I hadn't heard until this year. So what does that mean? It just means taking a break from being within 6 feet or closer to folks so that we can help mitigate the spread should folks be coughing or sneezing. Try your best not to touch your face. Cover your mouth. That's why masking, double masking, it helps break down. It's not going to prevent folks from being infected, but what it can do is it can help delay the spread or stop the spread. Make sure you have medical attention if you identify that you are screening or that you have any type of signs or symptoms of infection. And then just make sure that you're paying close attention to the news so that you're as well informed as you can be. I want to thank all of you so much for your engagement today. Should you want to reach out to me and talk offline, please let me know. I'm here available to anyone, any one of us here on the call today, or anyone should you want to connect. Thank you.
Thank you very much, Melinda. And also thanks to James and Fabella. I mean, those were phenomenal tales of experiences that you had during this. We really appreciate that you came on and spoke with us. And Fabella, I can hear the emotion in how you felt with trying to triage patients. Triaging is something that we're not familiar with in the dialysis world, because in general, we have enough resources. Well, we do kind of triage every day, but not certainly to the extent where you had to feel like you were depriving patients of care and worried about it. And plus the conflict that you had with the physician staff, I'm sure led to some moral dilemma within yourself. So, and James also, I heard the same thing, trying to deal with your wife's pregnancy in the middle of the pandemic and all the multiple things that you had to do to keep your units afloat. It must have led to a lot of moral distress in both of you. And I can hear that in your voices, and I hear that in all the staff that had to deal with these issues. I think these kind of conferences not only serve to promote education in our members, but also a good conversation and perhaps a release in processing these experiences that are so distressing. And I feel it also. I work in an acute unit in Albany at Albany Med, and we also had to triage, and it certainly led to a lot of moral distress and to struggle with the number of patients that we had to take care of. So I wanted to just make a couple of quick observations because we need to go to our next presentation. But I really feel that part of pandemic preparedness needs to be part of the disaster response that we have. You know, we're responding to hurricanes. We also need to get ready for pandemics, because as Melinda said so well, we don't know when the next one will come along, and we can't assume it's going to be 100 years. I also want to say kudos to our area dialysis programs. They dealt with this, I think, in a spectacular manner. We got very few patients from the outside units. We certainly got none that were infected in the outside units during that time period. So they did a phenomenal job keeping patients in the dialysis units, telling them to stay there because the hospitals were struggling with a big COVID population. So without further ado, I just want to introduce Maarika Sterling, who's our next speaker. He started in dialysis as a certified hemodialysis technician at the young age of 22. She has her bachelor's and her master's from Russell Sage College. She is a nurse practitioner. She works at the Albany Medical Center nephrology practice. So she is a treasured colleague of mine. She covers 6 outpatient clinics and takes care of 180 outpatient dialysis recipients. She's been on the planning committee, as also Melinda has been, for the chapter conference. And this is the 3rd year. This is her 3rd presentation for us. And so I'm going to hand it over to Maarika. Maarika, thank you so much for presenting today.
All right, well, thank you for having me, and thank you everyone who hung in there during our earlier technical difficulties. And I have a tough act to follow. Melinda's presentation was excellent as always. And thank you to all the speakers that spoke about their experiences. It's pretty amazing stuff. All right, so I am going to share my screen. So I am talking today about racial disparities and mistrust in healthcare. As Jane introduced me, my name is Maarika Sterling. I'm a nurse practitioner at Albany Med. And this actually came about before all of the kind of national attention that you know, racial disparities and racism in this country got. And I kind of wanted to explain a little bit about how this presentation came, because I think it's an important thing for all of us to talk about. So it was actually born out of a conversation that I had with one of the doctors I work with. We were talking about some patients who were one was not taking their blood pressure medicine, had very high blood pressure. One was not showing up for dialysis and had endocarditis and was missing antibiotics. And I said, you know, I was just sort of expressing some frustration about how this was so hard. My colleague said, well, I think they're really mistrustful. And it kind of shifted something in my brain. And I had never really thought about that before. Both of these patients were Black women. And I suddenly was like, I never thought about the level of mistrust that I know is there from, you know, some of the things we're going to talk about, but it got me interested in it. And as I started to study and look at racism in healthcare, it, you know, kind of gave birth to this presentation. So I hope everybody, you know, learned something. I wanted to start with this quote. The problem is that white people see racism as conscious hate, when racism is bigger than that. Racism is a complex system of social and political levers and pulleys set up generations ago to continue working on the behalf of whites at other people's expense, whether whites know it, like it, or not. And why I wanted to start with this was because I think when we hear the term racism, our knee-jerk reaction as white people is defensiveness. I'm not racist. I don't see racism in healthcare. We don't see that kind of stuff. We treat everybody the same. And I want people to start thinking about racism differently. And I think this quote really sums it up beautifully, because racism that we think of is that conscious hate, the KKK, terrible names, that's what we think of as racism. But we have to start looking at those political levers and pulleys that are set up that I'll get a little bit further into in the presentation, but that's really the meat of where these racial disparities are born from. So I think it's important for us, and my hope in this presentation is that people will start to think about things a little bit differently. We have all been indoctrined basically to see the world in a certain way, which is those pulleys, political levers that work on the benefit of whites. So this is really something that is important to me, and I hope that it opens up people's eyes a little bit to some of the things that are happening and behind the scenes. So the objectives for this presentation are to study the role of implicit bias, structural racism, and the legacy of slavery in the development of racial disparities in healthcare. We're going to explore the concepts of medical mistrust versus noncompliance in Black Americans. And we're going to discuss ways to identify and address disparities in racism in healthcare and increase the trust between healthcare providers and people of color. So there are several forms of racism. Structural racism is that system, that pulleys and levers that work together to kind of create a system that has a default white setting, is what I kind of think of it as. So it's the normalization of historical, cultural, institutional, interpersonal systems that benefits whites while producing adverse outcomes for people of color. It's the most pervasive form of racism, and it encompasses all aspects of society. So that's really that implicit bias that we're going to talk about a little bit further down. Institutional racism, discriminatory practices, and policies within organizations. So when we're talking about criminal justice system, we're talking about healthcare, even some things like real estate. There's been some stories in the news where they've done, had people come in to do an assessment of a property, of a house. And if the homeowner is seeing that they are a Black person versus a white person, there is a huge difference in the amount of value that that house has. So, you can look into that, but that has real world effects. If you have somebody who's selling a home and they take a $30,000, $40,000 hit, those are kind of the effects of institutional racism. And that's not even getting into, a criminal justice system, which when you look at sentencing practices, arrests, all of those have huge differences. I mean, there's, some people, you have exactly the same crime, exactly the same judge, and you can have a 15, 20-year difference in sentencing based on race. And of course, racial disparities in healthcare, which we are going to talk about more. Interpersonal racism is what most people think of as racism that we experience. And that's racism that occurs in interactions between two or more people. So that's when you have name calling or very overt racist acts towards other people. And then there's individual racism. That's your personal beliefs. They may not be shared. That might be, you may say, I'm not a racist person, but you might get nervous if you're walking down the road and you see a group of Black men coming towards you. Those are the kind of individual things where you don't act on them. You don't say anything, you don't do anything, but that kind of awareness is there. So one of the driving forces of racism in this country, and especially the sort of not as commonly recognized racism, is implicit bias. So here's a picture of Trayvon Martin, who was 16 years old when he was shot and killed. And the fact that he was seen as a threat to a grown man who was walking down the street feeds into that idea that we have stereotypes and attitudes that affect our behavior in an unconscious manner. So this isn't something that you are aware that you have. This is unconscious. This is just that nervous feeling that you get if you see someone that looks different from you. It can be across racial lines. If you see someone Middle Eastern and you think, oh, I wonder if they're a terrorist. I mean, we are fed this kind of ideas that perpetuate this bias that we're not even really aware that we have. Implicit bias can be negative or positive. Sometimes, you know, if you think about, oh, all Asian people are good at math, or it's always just an unconscious feeling that you have towards a group of people. It's involuntary. You don't think about it. It's not a conscious thing, but it is really pervasive, and it is across this whole country. We all have it, whether we like to think of it as not or not. I can't tell you how many people that say, I'm not racist, but they have these implicit bias. It's almost impossible not to have them growing up in our culture. They most often favor people who are similar to us. So the perceptions that you have are usually going to be positive towards people that look or live like you, but they can be changed. And later on, we'll talk a little bit about some of the debiasing techniques. There's a wonderful resource, the Harvard Implicit Bias Test. They have them for all different biases, basically. And if you click on that link, I'm hoping that this will be available, but if you just Google the Harvard Implicit Bias Test, and it's not perfect, but it will give you an idea. It's word associations, and it will go through, you know, kind of just the things that we think we don't do, but it will show you kind of where you fall. And I took a couple of them, and they are definitely eye-opening and pretty interesting. So implicit bias, how do we get them? We know they're not great for most things, but how do we prevent them from happening? So they're lifetime associations that we hear. They are pervasive within our society. So they can be based on anything: race, ethnicity, age, sexual orientation, religion, socioeconomic status. And they're developed through direct and indirect messages. So your family culture, if you have a family that is very insular and doesn't really interact with people that are different from you, you're going to be more likely to believe negative things from people that don't look familiar to you. And familiarity with diverse populations. If you've never had any kind of meaningful relationship with someone who is Black or someone who's Asian, you're more likely to believe things that you see in media portrayals, news stories. If on the news every night you're hearing about, you know, gangs and violence, and all of the mugshots that they're showing are Black men, you're going to associate that. And if you don't have any positive exposure, you don't, you know, you're not as likely to disbelieve that information. Another very pervasive form is within media. So I have a couple of listed stereotypes. The Black best friend, that's very popular in movies. And the role and the issue with some of this is, you might say, well, that's a positive person. You have a friend and they're Black. But the role is almost always that they don't have much going on in their life. They're solely there to support the white person. They're solely there to be a caretaker that's nurturing and rational to their white friend, meaning that they're not quite a whole human being on their own. They're solely there for the benefit of the white character. The thug, which, you know, most movies, if you have gang members, if you have criminals, if you have drug dealers, generally they're going to be represented by Black men. The angry Black woman, so that's the, you know, hair twirling, fingers going, you know, angry woman who's yelling. And those kind of stereotypes are really damaging, especially when you have in healthcare people who need help. They come in, they are in pain. They're in the ER, and then people say, oh, she's an angry Black woman. She's overreacting. They're, you know, and we see this a lot where people end up dying later in a parking lot or at home because they didn't receive the care because of this perception that they were just angry. They had an attitude. They were not, you know, listening or participating with what the staff member was trying to do. They actually had a show, Married to Medicine, on I think it was on Bravo, and Black women physicians petitioned to have the show taken off the air because the stereotypes were so damaging that they felt like it really would, you know, damage their integrity as, you know, physicians, and the seriousness that people would take. So those are all, you know, and then these are all stereotypes that when you break it down, they're relegating Black characters to supporting roles. So they're not whole humans. They're purely there to act as a support or to move forward the white character. You know, the movie The Help was criticized because all of the Black characters, they never moved anywhere. Their sole role was to help Skeeter to publish a book so that she could meet her full potential as wanting to be a writer, but none of these other characters ever moved beyond the, you know, their own confines of their experience. So these, you know, roles have to start to change in media. We have to start to look at it as a whole picture and a whole person, because it makes it much easier for us to dehumanize people when we see this constantly in media, that this is, you know, that they're solely there for the movement and benefit of white characters. So the second part of this is the legacy of slavery and health disparities. And I hear a lot of times people will say, well, slavery ended a really long time ago. It doesn't have anything to do with what's happening in the world today. And that really could not be farther from the truth. Many of the things that we have, and later on I have another slide that kind of talks a little bit more about this, but what we have in this country, when we look at healthcare, and when I was in nursing school, I learned this, you know, well, Black people have higher rates of diabetes and high blood pressure. Black people have higher rates of this, and this. But what a lot of, what I think is missed a lot is that we are looking at Black people in America, and that information is based on enslaved people and their descendants, and who all lived in less than ideal conditions, with less than optimal food, less than optimal access to healthcare, in very stressful environments for all of their lives. So when we're looking at the disparities in healthcare, we can easily say, well, people are, you know, living in lower socioeconomic environments. People don't go to the doctor. People don't take their medicine. But what is the underlying issue with all of this? So enslaved people and their descendants were used for centuries in the US to identify the characteristics of their entire race. And it perpetuates the belief that Black people have poorer health outcomes due to an inherent racial weakness, not disparities in economic status, nutrition, or access to healthcare. So this narrative constructs this idea that they have some inherent weakness that we don't have, but you're ignoring a generations long history of you know, poor diet, poor healthcare access, and a lot of stress. So I think we need to start to look at really what the underlying causes are of these of slavery in this country. So if implicit bias is really the backbone of racism in this country, I think that this is the foundation, and this is really the ground floor of where a lot of these beliefs come from. And this is Thomas Jefferson, and this is something that he wrote about Black people. And I'm not going to read the entire thing, but I found it when I was researching why we have racial adjustments for incentive spirometry, which doesn't make any sense because we don't really have any actual evidence of why Black people's lungs would be different than white people's lungs. Spoiler alert, it's because they're not. But why do we even have this belief? Why do we have these racial adjustments? And a lot of it came back to Thomas Jefferson. So you can read through it at your leisure, but the stuff that jumped out to me is what I highlighted down here. And when I was talking earlier about the stereotypes in media portrayals and talking about how you look at sort of less than or not whole person, and this is I think, the root of it. So when you look at the biggest one for me was their griefs are transient. So when you look at the treatment of Black people in this country, separating families during times of slavery, even now where we have mass incarceration, so you have lots of families being ripped apart by the criminal justice system. When you look at how many more Black people are dying from COVID-19 than there are white, their griefs are transient. They're not feeling that as much as we do. they're not grieving their family, their loss as much as we do. This is really the heart of racism, that somehow these things don't affect people that don't look like us the same way. They're more ardent after they're female, but love seems to them to be more an eager desire than a tender, delicate mixture of sentiment and sensation. All of these things are basically saying that Thomas Jefferson believed that they didn't feel any of these painful things at the same level that we do. You know, so if you are whipping somebody and leaving those scars that were so horrific on the earlier picture, they don't feel it as much. So it's okay if you are putting somebody to work for 18 hours in a field, their lungs aren't as strong, so they need that extra work. All of this, you know, from hundreds of years ago has impacted our perceptions of Black people and of, you know, racism all these years later. So we have to really get back to the beginnings of all of this, I think, if we want to fully understand the effects of slavery, the effects of racism on the disparities that we have in healthcare. So there are so many fallacies about race-based health, which I did talk about a little bit, but this is a nursing textbook from 2017, not so very long ago, and they have made an effort to be diverse and culturally aware, but this is another form of racism, and we have to start recognizing that. This textbook has since been pulled, and they did acknowledge that that it was racist. But some of the things, like the slide previous, that Black people have inferior lungs, and this they used to excuse people working tremendously long hours in fields in horrible conditions because their lungs were weaker and they needed to be strengthened. So that was an okay thing for them to do. Higher rates of hypertension and diabetes. Oftentimes you have people that are living in food deserts. You have unsafe areas for exercise. So all of these things, you know, play a role in the higher rates of hypertension and diabetes. And one of the most shocking ones that I saw was that there was a 2016 study, so this was 4 years ago, that found that 50% of medical students and residents that were polled for the study believed that Black people didn't feel pain the same way that whites did due to differences in their skin or nerve endings. So that has real world damaging effects. If you have people that are in pain, that are suffering, and you don't believe that their level of pain. And even in this textbook, Blacks often report higher pain intensities than other cultures. They believe suffering and pain are inevitable. So, you know, we have to start to think about these things in a different way and start to be aware of these things that, you know, even when I was in nursing school, these were things that were taught. So we have to be able to call them out and recognize the damage that these kind of beliefs cause. So this is just going back a little bit more to that idea of genetic predisposition. International data demonstrates a wide variation in hypertension prevalence among Black and white people. There are no differences internationally between the rates of Black and whites with hypertension. So this is a phenomenon that is just affecting the US. The disparities are unique to this country. So these hundreds of years have contributed to the health disparities that we have. This isn't just a single experience where, you know, we can fix this one thing. We have to really go back systemically to the causes that are so rooted in the cultural and systemic racism in this country. Some of the other things that we really do need to look at are the lower income neighborhoods that have less access to quality foods and sufficient healthcare, obesity levels, areas where there, as I said before, are food deserts, access to healthy foods, transportation barriers, lack of safe play or exercise space, and a phenomenon called weathering. And weathering is advanced aging caused by the wear and tear from fight or flight responses, and just the kind of flood of adrenaline from living in a country where you are so often living in fear and anxiety purely because of the color of your skin. So weathering is something that shows up when they do autopsies on Black men. They'll sometimes find that their heart, their blood vessels are all aged disproportionately to their chronological age, and that they feel that this is caused from weathering, which is just this kind of long-term stress. And if you think about what we think of causes high blood pressure, stress is a huge factor. So how much of these disparities are from the society that we have people living in? So another popular argument about racial disparities is that more Black people live in poverty than white people, and that they can be explained away by socioeconomic status. But there is more and more evidence that shows that race and ethnicity remain significant predictors of the quality of healthcare received, regardless of socioeconomic status, health, or education. So what we're seeing is that this has very little to do with income, with education, or with education levels, any of that. We have, what we're seeing is that this is based purely on the color of people's skin. So we have to start to shift the conversation away from thinking of it as a socioeconomic status issue to one that is purely of race. Blacks have a higher rates of death, lower rates of interventions. Racial disparities are found in every aspect of healthcare. So mental health, cancer, heart disease, and even dialysis. Black women are 2 to 3 times more likely to die from pregnancy complications or childbirth than white women. Infants born to Black mothers experience the highest rates of infant mortality. Many of them are on par with third world countries. Black women are more likely to die from breast cancer than white women, and they're more likely to die from stroke. Heart disease and cancer are among the leading causes of death across all race, ethnicity, and genders. But Black people were 30% more likely than whites to die prematurely from heart disease, and Black men are twice as likely as whites to die prematurely from stroke. So since this is dialysis nurses, I had to do a little bit about ESRD. So even though Black people represent a smaller portion of the population, they represent a third of ESRD patients in the US. So there's a disproportionate number of Black people that are on dialysis versus white based on their population. They're more likely to need dialysis. And Black patients with CKD are less likely to be seen by a nephrologist prior to renal failure. They have much lower rates of PD and transplant referrals and a longer dialysis vintage at the time of transplant. Once on dialysis, Black patients are less likely to meet quality indicators such as hemoglobin, AVF placement, and clearances. And I think that there's a kind of a multi-level issue that's going on with why we have this. You know, obviously stress, social and economic stressors are going to lead to higher hypertension rates, having you know, education. If you're not seeing a nephrologist prior to needing dialysis, you are less likely to pick a treatment modality like home dialysis, and you're going to have less interventions to prevent needing dialysis. So education and understanding of the disease, if you're not seeing a nephrologist or if you're not referred to a CKD education place, you're not going to have that education and information in place. Mistrust and lack of care. A couple slides from now, I'm going to talk about some of the historical factors that contribute to mistrust of Black patients. But that's a huge thing. If you are seeing a patient and they don't trust that you are giving them information that is for their benefit, they're less likely to adhere to that. So making sure that you have trust with your patient is really important so that you know that they're doing everything that they need to do to stay healthy and as off dialysis as long as possible. And then this goes hand in hand with medication adherence. If you have people who don't believe that the medication you're giving them is actually going to help them, they're not going to take it. So oftentimes I'll see this where I have a patient who's on, 8 different blood pressure medicines and they're still, 220 over 130. And you're like, how can you be taking all of this meds? Oftentimes, sometimes people won't take medicine until they're symptomatic. They have a bad headache, then they might take all of the blood pressure medicine you gave them, which results in their blood pressure dropping very dramatically. They feel horrible, and then they say, those medications don't work. So making sure that you are really talking to your patients, that you know what they're taking, trying to build that trust so that they feel comfortable saying, you know what, that medication made me feel weird. I had heart palpitations. Okay, let's try to switch to a different calcium channel blocker, or my legs are getting swollen. So that's where that trust really comes into play, where we have to make sure that we're having those conversations and that we are not alienating people and their concerns. Access to health promotion. So again, back to that same thing. If they're living in an area where it's difficult to obtain healthy foods, where there are not safe places for people to walk, if they can't get to a pharmacy. I've run into this several times where I prescribe medications for patients for high blood pressure, and they keep saying, oh, I forgot to pick it up. I forgot to pick it up. And when you kind of sit down and chat and say, listen, this is really important, you know, what's going on? Well, I only have transportation to get to dialysis and home, and I don't have any way to go to the pharmacy. So there's sometimes things that we don't think of. You know, I have a car. I never think about that being difficult. You know, you don't have anyone in your family that can drive to the pharmacy to pick up your medications, but we have to start to learn that our experiences is not the same that everyone else is, you know, experiencing. So we have to start to shift our focus a little bit from, tell me what the barriers are that you are having, and then let me see what I can do to try to help. So Melinda covered beautifully the coronavirus pandemic, and we had talked a little bit. She had the slide that showed some of the disparities, and I wanted to just, I found a really great journal article that talked about this, that, you know, previous public health crisis created a historical precedent that's important to avoid. And that's the idea that minorities are suffering these disparities because of some kind of inherent weakness that they have.
Talking about implicit bias, like things about the American culture that, like, white people get offended when you say they're racist. They say, I'm not racist, but they don't understand that things were put inside our heads just as true.
I don't know if Bonnie meant to intersperse that, but it's still good information. So, you know, when we don't have the context to understand why there are these disparities, it's really important for us to look at it as an entire picture and not just focus on those disparities that are popping up. So yes, there are disparities that where we have more
Why don't you call it
Hispanic.
not unbiased?
Bonnie, I think you have to mute yourself. All right, so beliefs that certain races are predisposed to certain diseases, can't talk, genetically or through stereotypes or behavior. So some of those things are, you know, socioeconomic status, territorial stigmatization, which is kind of the idea that certain neighborhoods are a blemish and that area impacts the residents. So if you're from a certain neighborhood, you're automatically going to be stigmatized because of that. So you will see that a lot in access to care, and back to the, you know, the idea of weathering. So people are going to be more likely to get sick if their bodies are already under stress and already have that fight or flight reaction that's constantly going on. So what are some ways that we perpetuate racism in healthcare? And some of this is unintentional, and I think it's really important for us to recognize that this is not always something that we are doing intentionally. But some of the damaging stereotypes, Black people are less likely to be compliant with treatment or medications. And this goes back to that same idea of, you know, implicit bias, the same idea of mistrust, and how much of it is non-compliance and how much of it is mistrust. Deeply flawed attempts at cultural diversity. Going back to that textbook, if you have, you know, in school, I remember a presentation that we had to do where we had to pick a different culture and we had to study it. We had to come up with a treatment plan that was adherent to it. And I think that if done well, those are really important. But I think that when you have primarily white people setting up a system, looking at diversity without actually getting input from a diverse population, that can actually just, you know, make things worse and kind of just perpetuate these divides and this misinformation. So any educational materials that are perpetuating the myth that other cultures experience illness differently or require different treatments. So if you have anything that's saying, well, Black people have weaker lungs, or, you know, some cultures don't, I'm trying to remember, I had some of them written down, but I don't have my sheet, but, you know, like how they'll react to pain or different treatments, or, you know, all of it. At the end of the day, healthcare is treating a body, and all of the bodies are the same. So while it's important to have awareness of different cultures, and most often, if you can have a dialogue with somebody and just say, is there anything that I should be aware of? And they will tell you. If you start making assumptions, you are likely to get something wrong. So it's much better to just be upfront and say, I'm just curious if there's anything that I should know. And you can do this, you know, to anyone. It's really, you know, just kind of, you know, there are different religious practices. It's not a racial issue. It's really just a human issue. Is there anything that I should know before we start treating you that, you know, you want me to know, or that's important for you to know? And I think the biggest things for us is not examining our own implicit bias, not addressing the disparities in our practice. It's hard to recognize these things. Nobody wants to think of themselves as a racist person, but it's very hard to live in this country and in this culture and not be at least race aware, which might be a more comfortable term for people than, you know, racism. But at the end of the day, if you are treating anybody differently in healthcare and the criminal justice system, it's all based in, you know, in race. That is racism. So we have to start to think of it as, you know, how are we playing into this, and what are the things that we can do to change that? So it's an uncomfortable thing. It's a hard thing to think about, but if we don't start to make that shift, it's not going to get better. So if you're ignoring, turning a blind eye to racist practices, and again, that's not necessarily an overt racist action. We've always done it this way. We have always adjusted for, you know, GFR based on race. We've always adjusted for incentive spirometry based on race. And they're finding, you know, most labs and hospitals are getting rid of the race-based GFR adjustment because they found that it's not correct, and that we were missing people in CKD because of it. So we have to start to shift, and, you know, oftentimes you'll hear, you know, racist jokes, you'll hear these kind of racist stereotypes that are being perpetuated. Try to find a way that you feel comfortable, but to say, you know, that's not really funny, or that's not really okay, or, you know what, I did some research into this, and that's actually not an accurate way of, you know, assessing this, or this. So it's important for us to recognize and to start to make those changes within ourselves and within our practice. And ways we perpetuate racism in our lives. And this is kind of more global. Microaggressions. Those are common brief comments or behaviors that communicate hostile or negative attitudes towards stigmatized or culturally marginalized groups. So microaggressions can be, they're very quick. I have a slide on the next one. I think I'm going to jump over here so I can just kind of go over them. There's a couple different themes. Alien in your own land. My father was born in a refugee camp in Germany after World War II, and he came here on a boat when he was 5 years old. Not once has anyone, even before I got married and I had a very ethnic sounding last name, not once did anyone ever say to me, you know, where are you from? Or, you know, sometimes people would ask me about my name, but never in a negative way. It was never implied that I was not American, that I wasn't a foreigner. No one ever told me to go back to where I came from, or told me that I spoke English well. But you have you know, especially with, you know, Asian Americans or Latino Americans, it's assumed that they're foreign born. And the message is, you're not American, you're foreign, you don't belong here. Even for people who have been born here, people whose parents have been born here. Ascription of intelligence, you know, and some of these are viewed as positive or compliments. You're so articulate is a very common one when you talk to people who are Black and you say, oh, you don't sound Black, or you don't act Black, or you're so articulate and well-spoken, you're so educated. But you're basically saying, the message there is that most people of color are not as intelligent as white. So at the heart of it, it's you sound white, you act white. And it's kind of sending the message that that's a good thing because somehow whites are better than Blacks. And that goes back to that same thing that we've been talking about. Color blindness, statements that white people don't want to acknowledge the race. So I don't see race, that's very popular with healthcare. And I think that most people, it comes from a well-meaning place, but when you talk about color blindness, you're basically erasing those people's experiences, which are often negative and painful. So if you just say, well, I don't see any of that, you're ignoring that whole piece of their experience and that pain that comes along with it. So it's really dangerous to think of it as, that we're all one race, we're all the human race. You're ignoring, the issues that they're facing, and you're kind of dismissing them without, as if they are not warranted. You can read through the rest of them, but, criminality, that's another one, somebody, clutching their purse or checking their wallet if they see a Black or Latino person approach them. So I think that this is a good kind of example of what racial microaggressions are. Whitewashing, colorblindness, we did talk about that. Standards of professionalism. So recently there was something that came up about Google, and if you Googled professional hairstyles, they were almost all white women. If you Googled unprofessional hairstyles, they were almost all Black women. So the idea that professionalism, if you have, you have natural hair if you're a Black woman, or you have dreads, that these things are somehow unprofessional or discriminating against people with Black sounding names in schools or in the workplace. There was a study that showed people with more education with a Black sounding name received less callbacks on job applications than somebody with much less education with a white sounding name. And another issue that I think is important to recognize is the white savior mentality. And even when I said I was doing this presentation, I had a couple people that said to me, don't you think that somebody who's, Black or a person of color should be doing this presentation? And absolutely, I think that we should have more representation across, all aspects and more diversity in all workplaces. But I think that what we have done for a long time is made it that racism is not a problem for white people, so we don't really have to do any work to fix it. And I am hoping that I'm doing an okay job of this. I'm sure that I will get some things wrong, but the takeaway from this is that we all have to start working towards fixing this, and that it's not fair to put the entire burden of fixing racism on Black people and people of color, because when we do that, we're basically saying this doesn't affect us, so it doesn't really matter. And it's a huge burden to put on a group of people, especially a group of people who we often don't even believe when they talk about. If you hear somebody tells you, I had a terrible experience at the hospital. I went in, I was ignored, nobody would treat my pain. A lot of the time people will say, well, that must have been a bad experience. You had a bad doctor, you had a bad nurse. They don't look at it as a systemic racism issue. They look at it as a single bad experience. So not only are you putting the burden of solving this problem on Black people, but you also don't listen to them when they talk about it. So we have to start to take some ownership, I think, as a community, all of us, to recognize that this is an issue that affects all of us, that we have to do, and we have to do as white people our part to try to recognize our role in it, start to change the normal of what we see. We have to stop looking at, whites as the default setting, the normal, and everybody else is different, and that racism only affects those people. All of us have cultures, and all of us have belief systems. We have to start to recognize that, the privilege that we experience as whites is this idea that this is this is the normal, and that other people that are dealing with these things, that's their issue. We have to start to look at it as all of our issue. And like I said, I might not do a perfect job, but I think it's important for all of us to try to do our best, to start to research, to start to read, to start to understand, and not to try to fix racism without understanding the issues, the context. We have to make sure that we are listening to people who are willing to share their experiences, and not expecting that all Black people are going to be willing to do that. Because for some people, it's really exhausting. If you're constantly, berated with systemic racism in this country, and then to also have to do all of the work of convincing people that it exists and changing their mind and providing all the information of how they should start to change to make it better. Racist jokes perpetuate stereotypes. So, you'll often hear people say, I'm not racist, but this is a funny joke. And silence, it's interpreted as agreement. So if you are seeing this and you're not hearing, people complaining, they're going to interpret that as agreement or as consent. So we went over that. I did talk about color blindness already, so I will skip a little bit of that, but it can be very dangerous and counterproductive if you don't see color. It's rampant in healthcare, ignores the stories and voices of Blacks and people of color. How do we combat that? So you have to ask and listen to the experience of others. They might be different from yours. They might be very different from your experience. I recently, when I was pregnant, I was 36 with my second. I never had high blood pressure, but they were concerned. And because I was older and I had very mild kidney disease, they put me on a baby aspirin. They sent me to maternal fetal medicine. They were very, very cautious, across the whole board. I had a wonderful experience. And I knew someone who was a Black woman who had very high blood pressure through her entire pregnancy. And it wasn't until she was in her 32nd week where they put her on a baby aspirin, which should have been standard practice at the beginning of the pregnancy. And it wasn't until I said to her, you need to ask them why you're not taking medicine. Tell them that, your friend is a nurse practitioner and wants to know. And suddenly she was placed on labetalol. So the experience that I had with a practice was the same practice, was very different. And this woman had seen 5 different providers. So this wasn't an oversight. Every time I went to the office, I had a printed out sheet of all my meds. And so this wasn't something that was just missed, and we have to start to see this, that just because you had a great experience somewhere, it doesn't mean that that's going to be the same experience that somebody else has. Don't turn it around to your experience. So if somebody says to you, I went to this practice and I had a really horrible experience, don't say, well, I go there and I never had any problem. I've always, received great care, because your experience and their experience is different. Don't dismiss negative experiences as a bad apple or an isolated incident, because you're diminishing the value, diminishing that painful issue and not addressing it. And I know that when Elizabeth Warren came out a few years ago and said, healthcare doesn't treat Black women well, there was a tremendous backlash. And even nurses that I knew that were people who I think, think of themselves as allies and, progressive people that were like, this is outrageous. We are not racist. Nurses are not racist. I think the outrage was really misplaced, because she was telling the truth. There is tremendous evidence. If you just Google, health disparities, you will find a plethora of, scientific evidence that this is a real and very dangerous and damaging phenomenon. So the outrage should be on, the healthcare system, not towards Elizabeth Warren. We have to really start to recognize our role in the perpetuation of this and make sure that we are upset about the right things. So non-compliance versus mistrust. I touched on this a little bit earlier, but Black patients are less likely to adhere to prescribed medication or treatment. Most of the studies that have been done looking at this phenomenon focus on the differences between Blacks and whites in medication compliance. And the most cited causes are usually cost, education, and access. So if you have trouble getting to the pharmacy, if your medications are expensive, or if you don't understand why you're supposed to be taking these medications, all of those are reasons that you may not take your meds. And all of those are absolutely valid reasons. But are we ignoring something else? Are we ignoring the context and the cause of why people are less likely to take their medications? Mistrust is very common with Black patients and white healthcare providers. And negative experiences with healthcare are common historically and currently. So some of the issues are, sorry. All right, so slavery in medicine. I talked a little bit about this earlier, but there was widespread medical experimentation on enslaved people. So a lot of the information that we have, even pathology, surgeries were performed without consent. All of these things were done on enslaved people without consent. So this obviously is setting up a precedent for a lot of mistrust. The Tuskegee syphilis experiments, a lot of people learned about this in school, but basically they had a group of Black men who they knew had syphilis. They told them that they were treating them so that their syphilis would go away. But the purpose of the study was actually just to watch and see what happened to untreated syphilis. So they allowed this group of people to basically die of syphilis, which is a horrible way of dying, and also knowingly allowed them to continue to spread syphilis to other people in the community because they thought that they were cured. So that wasn't so very long ago. So there are people whose grandparents experienced that or were aware of that. And that's obviously going to make people very suspicious of, medication and of treatments. And is this really doing what you think that it's, supposed to be doing? Dr. J. Marion Sims was a gynecological surgeon who did a lot of surgeries without consent on women. He did a lot of studies, so he was constantly using women without their consent to perform surgeries. And obviously, this is very damaging. There was a few years ago, they were talking about taking down his statue just because of the consent issues. A lot of the surgeries that we do today are based on his studying, but the ethical questions that have risen from that. And Henrietta Lacks, there was a book a few years ago and a movie called The Immortal Life of Henrietta Lacks, which I highly recommend. But she was a woman in the 50s in Baltimore who had cervical cancer and ended up dying from cervical cancer. And they took her cells and used them and have made billions of dollars, basically. They are used in almost all human testing. They have been used over and over and over again because they keep growing and they keep populating. So most medications today have been tested on Henrietta Lacks cells. And the issue is that her children all live in poverty. Companies have made billions of dollars off of her cancer cells. Then some of the other, issues, those are historical, but what modern experiences? People are still experiencing longer wait times in hospital settings, less treatment for for pain, for different medications. So we really have to work on not just we have to look at the historical context, but we also have to look at the modern experiences that people have. And if you have people that are waiting for a long time, or they're coming into the hospital with chest pain and they're being ignored, and even some of the more we've heard of Serena Williams' experience when she had her daughter, and she had a history of blood clots and felt that she had was having a pulmonary embolism, and she was it was only she was very lucky that she survived. So some of these things are still happening. Many of these things are still happening. We have to really start to change the experience if we want to increase trust. So what are the true barriers and what are the the false barriers that people have in compliance and in mistrust. So talking to patients about the barriers they face, asking open-ended questions and using active listening techniques is very important. And it's going to take some time to earn trust of people. You have to follow up, keep your promises. If you say to somebody, I'm going to look into this, make sure that you get that information back to them. If you say, I'm going to talk to so-and-so about this, you know, make sure that you, even if you're checking in, I did call, I didn't hear back yet, but I am working on it. You want to provide care with empathy and understanding. The experiences and barriers and struggles are likely going to be different than yours, but it doesn't mean that they're any less valid. Try to work within their goals, and they may be different goals from yours. Previous negative experiences may cause wariness or resistance. So don't go into it with, I'm going to earn your trust. And the first sign that somebody is, you know, wary of you, you give up. So this is something that a lifetime of negative experiences are not going to be erased just because you decided that you're going to earn someone's trust. You have to really recognize that this is a lifetime issue. And oftentimes, you know, grandparents, parents have passed down this mistrust. Encourage diversity in the workplace. Black patients and Black providers have better outcomes. They found that Black doctors, when caring for Black patients, write longer notes. They set up more referrals. They follow up with more issues. Identify disparities within your organization and combat them. Are there differences in hemoglobin or PT over V or catheter rates in your facility? You know, take a look at it, see if there's less referrals for home therapies or for transplant, and take initiative and start to change that. So what can we do as a group of people, you know, that with this information, start to recognize the disparities as racism, because that's really what it is. If you have any groups that are receiving less care or different care based on their race, that's healthcare disparities, that's racism. So what is the, you know, context, and explain, how do you look at disparities and understand where they're coming from and what their cause is? Dig deeper, question things, do more research. There's a lot of information on the internet, a lot of journal articles that study this. Look at your own organization and see what can be done. Are they meeting quality indicators? Are you giving up on patients that are non-compliant? When really maybe you just need to spend a little bit more time talking to them and figuring out what some of the barriers they're facing, and how much of it is earning, you know, how much time do you spend earning people's trust? Some of the other things, we want to make sure that we are recognizing mask racism. So if you see someone who's coming in for the same thing, or every time they come in, their blood pressure is really high, and you just kind of say, oh, they're non-compliant, they're not doing what they're supposed to be doing. Dig a little bit deeper. You know, often when I was in the hospital, my first clinical that I ever did, I was at St. Peter's Hospital, and there was a young Black woman, and she was there for abdominal pain, and every nurse that I worked with said, oh, she's just here for drugs. And no one that I can remember had really put in any testing or anything to kind of really see what she was there for or what the abdominal pain was. It was just she was dismissed because they had labeled her as a drug seeker. Similar to that, you know, oh, they're on 10 out of 10 pain, but they're on their phone. This is feeding into that. Well, they don't feel pain the same way that we do. So all of these, you know, negative stereotypes are forms of racism, and in order to start to change our culture, we have to recognize that as racism and start to really address those within our organization and within ourselves. So some of the debiasing techniques, awareness that you hold an implicit bias. So if anyone's interested, taking the implicit bias test will give you some information about where your biases are and how severe they are. Try to expose yourself to diverse populations. So if you if you look around at your friend circle and almost everyone is the same race as you and you have very little exposure, you know, I think one thing that's great about nursing is that there are so many different cultures in nursing, but think about your friend circle. Think about the exposure that you have to different populations and how that affects your perception of the world. Because if you are surrounded by other white people, their experiences all mirror yours. You're not going to believe that racism exists at the level that it does in this country. So you have to start to kind of try to expand that circle a little bit, have meaningful interactions with people who look different than you, have different experiences than you. And that's going to require having hard and uncomfortable conversations, because we have to get comfortable with being uncomfortable. This is definitely something that a lot of people struggle with. And I think people stay silent because they don't know how to talk about these things with people, because they're afraid of being offensive, or they're afraid of getting it wrong. So my experience is that most people will be open to having these conversations with you if you come from a place of genuine concern and hope that you can change. So I think it's important to, try to find people who are willing, but also remember that you don't want to put the entire burden. Don't say, oh, I saw this presentation and it made me think about, racism differently. Can you tell me some stuff that I should do to stop being, racist? You want to make sure that you are doing it respectfully, and do some of the work yourself. If any of this opened up your eyes and you are thinking about things differently than you did before, and you do have some friends that are Black and you think, oh my God, I never thought about this. There are tons of things that you can find. I have, I think the next slide it is, a list of books and movies and things that you can kind of, read through on your own, but try to not put so much of the burden of dealing with racism on, of other people, but do try to have those conversations. I know that sounds a little counterintuitive, back and forth, but just being aware that you don't want to put the entire burden of this on people of color, but also listen without explaining, excusing, or justifying. If somebody's telling you a bad experience they had, you want to make sure that you are being respectful of that experience that they had, and don't make it about you. Sometimes we'll say, oh yeah, I had a terrible experience. This is a deeper issue. This is not just a bad experience. This is just not, receiving bad care at one hospital because, someone, this is a much deeper rooted issue. So countering stereotypes. So if you can have negative stereotypes, you can have positive stereotypes. Some of the things we'll watch movies like 42 or Hidden Figures, and you see these characters that are up against racism and you think, oh my God, you empathize with them, but we don't have that same level of empathy with people that we interact with every day. So kind of trying to look at, ways that we can change the negative stereotypes to something that's positive. Fostering fairness, and fairness is, the idea of equality and equity. We want to get ultimately to a place where race is not a factor in the care that we provide, but we are not there yet. And if we don't recognize that, if you have someone who is struggling, spending a little bit more time talking to them, working a little bit harder to get them to trust you, that is fair, because if you have people who have spent their entire life feeling that healthcare providers don't listen to them, don't care about them, spending that little bit of extra time is part of that fairness of trying to get us all to the same level where we don't have to think about this. It's going to require all of us to kind of work on this together, recognizing the roles of implicit bias and structural racism, and that when we get to that point, we're going to be able to, hopefully at some point, this will, become something that we don't have to talk about as much. But right now we are not there. And this is really something that we all have to start to be aware of and work towards. So some of the resources, full disclosure, I have 2 small children, which hopefully you don't hear banging around because I came back because we got started later. But some of the resources, I didn't read all of these books. I thought Waking Up White was really wonderful. She was a white woman who really saw herself as an ally, who worked with, lower socioeconomic populations, and could never really connect or understand why she had so much trouble connecting. And I think that's a really good resource for people who kind of want to do better, but aren't really sure how, or don't really understand racism in this country. So I think Waking Up White is very good. White Fragility was also really good. And that talks a lot about the defensiveness that we feel automatically when we talk about racism. That it's like, I'm not racist, I don't want to talk about this because I'm not racist. You know, we have to start to recognize that. You know, the mortal life of Henrietta Lacks is not exactly about racism, but it is about, you know, kind of the treatment of people and the ethics involved. There's a very good, I think it was put out by the Institute of Medicine, Unequal Treatment, that goes over kind of, you know, healthcare disparities on a huge level. Some of the movies, 13th was incredibly eye-opening to me. It's about the 13th Amendment, talks a lot about mass incarceration, and that's available on Netflix. I highly recommend that to anybody who's interested in learning a little bit more. So these are all kind of resources. I know we're kind of going a little bit long here, but would definitely recommend anybody who's interested. And I think the biggest thing I hope people take away from this presentation is we have to recognize the things that we don't know and change. You know, obviously there are things that have been problematic that have been going on for decades. So now we know they're problematic. What do? Do you dig your heels in and say, well, we've always done it this way? Or do we say, wow, I never thought about it that way? So I think this is an important quote. Forgive yourself for not knowing what you didn't know before you learned it. So if hopefully this opened up anyone's eyes to kind of the issues of racial disparities and racism in healthcare, you know, I hope that this is the first step that leads people to do more research, to start to think about things differently. And, you know, the most important thing is moving forward from this place. And hopefully we'll all, you know, start to learn more. I'm still learning. There's things that I'm, you know, constantly reading, because I think this is so important for all of us to recognize. So that's it. I know this is a sometimes a difficult topic for people to talk about. Like I said, I am not an expert, but I can do my very best. You know, if people have questions or if they don't understand anything, this is my email. Please feel free to email me with any questions or any discussions if you feel like, you know, you think that there was anything I got wrong or anything that I didn't think about. You know, I'm happy to take those kind of criticism too, because I think it's really important for us all to know that we're not going to get everything right all the time, and that that's okay, and that we go forward from that, you know, learning everywhere. So I'm going to see if there's any questions. Let's see a couple from Melinda, and I think we're all good. So thank you everyone for
Maarika, somebody requested that you put your email up again, please. Monica Richter did.
Yep. Hold on.
And then
Oh.
thank you for
hold on. Is it up there or no? Hold on.
No.
I have to do screen share again. Okay. All right.
Okay. There's Maarika's email.
And there's lots of resources here too that are, you know, even just my references have a lot of articles. They're not all medical journals. I did get a lot of information. So I don't know if anyone has any questions. I'm trying to see if I can bring up the
Yeah, bring up the chat if you can. Bring the chat function up. If you could just put us back on Hollywood Squares, Maarika, that would be great.
All right, hold on, stop sharing.
Oh, nice.
All right.
Just to remind everybody that this is going to be archived, and Carol, I'm sure will send the link out for the archive. Am I correct, Carol?
Yes.
Here we are, not socially
I will
distancing.
send a link out to everyone.
Yes. I know we went a little bit over. I appreciate everybody's patience with our technical problems, and I can't thank the speakers enough, Maarika and Melinda, and also want to thank especially James and Fabella for speaking also. They were wonderful. Everyone was very much appreciated. I think this also calls to, we are not only nurses, but we're sociologists, because the social issues of our time present themselves at our doorstep. as they have always presented them at the doorstep of nursing. So this is nothing new. This will continue, and this is what nurses do. This is what makes me proud to be a nurse. Another really good book that I liked, and everybody that knows me knows I'm a bookworm, is Evicted, and it was written by Matthew Desmond, and it talks about the sociological issue of people becoming homeless and being evicted from their homes, and also related to Melinda's discussion, The Great Influenza. It talks about, it makes us know that this pandemic is not too much different than the pandemic of 1918. It's by James Barry. I recommend this read. It's very good and will give you perspective into what we've all gone through with this. I do believe that this pandemic was far worse than what we're seeing. So when I start really feeling sorry for myself, I just open this book back up and just remind myself this was way worse than what we are going through in 2020. So with no further ado, I'm going to ask Julia Mason to unmute herself and talk about the evaluation component and what we need to do to get continuing education credit.
Well, thank you, Jean, and thank you, everyone. I would like to, on behalf of Albany Medical Center, thank you for attending this accredited event for 2 credits. You'll be receiving an email either via Carol or via Albany Medical Center. So please look for that because we'd like you to put your name in. It's a requirement to get the CE as to how your name is spelled and your email so that you can get your CE certificate mailed out to you, as well as we want your feedback. These were 2 fantastic speakers and guest speakers. Very proud to have been involved with this, and we'd like to thank you for attending today.
Okay, everyone. So thank you for attending. As Julia said, Carol, do you have anything to add?
No, I just want to thank everyone for attending also. And Jerry, it was great to have you pop on. We miss you here in the 518. So it's great to see you.
Thank you.
I really
Thank you for including Rochester.
Oh, my pleasure. We have an office in Rochester now, just an FYI. But I thought the presentations were wonderful. So I want to thank all of the speakers. It's not just the time to do the presentation, it's the time preparing for it also. So I know everyone put a lot into it and we really appreciate it.
Yes, we do. Yes, thank you. Thank you. Have a safe, keep
Yeah,
safe.
everyone. Everyone.
Yeah.
Thank you.
Great to see everybody. Thank you.
Thank you. Have a great
Didn't
day.
call me.
Maarika, you have to end the meeting because you are still the
You want
host.
me to?
Oh, I'm the host now. Okay, thank you.